All right. Well, good morning.
Good morning.
I am Leslie Addison, and I am a child and adolescent therapist here in Aiken. I've been in Aiken for about the last 14 years, and I was recruited originally by Aiken Regional to work at Aurora Pavilion on the child unit. And I fell in love with Aiken the weekend they brought me up for steeplechase, and it reminded me of my hometown, Thomasville, Georgia. If you've ever been down there, very similar downtown areas, very similar in that it's got plantations with quail farms, which the horse farms reminded me of that, and so kind of fell in love. And then as many of you are church leaders, you know that one of the things that helps you fall in love with a town is your church home. And I'm a very active member of Millbrook Baptist and have a wonderful church family there. Met my husband here in Aiken on the week before a mission trip with Felicia. And I think she got tired of me talking about him. I was 29 years old and had been waiting for who God was going to send me. And we have two wonderful kids. Our son Brett is 7 and our daughter Caroline is 4. I almost said 3. She just turned 4. But we're glad to be here today. We're going to be talking, and I'm a mover, so sorry I'm not standing up on this because I'll fall off, and y'all don't want that. But we're going to be talking about child and adolescent mental health. We're going to be talking about some common diagnoses and also some common treatments. Now, we have an hour, and so I'm going to try, and you're going to see me glancing at my watch because there's not a clock in here, but we're going to try to be done early enough to where you guys can ask questions. But I will be around for the rest of the day, so feel free to seek me out and ask anything. But we will try to get that done by the end of the day. So, something I wanted to start with is understanding some childhood mental health facts. So 1 in 6, and if you were just in the first session with our psychiatrist, it was really profound to me when he had the birthdays stand up and you saw how many people in the room would have been affected by a mental health diagnosis. That ranged true for kids and teenagers as well. 1 in 6 has a treatable mental health diagnosis, okay? So you think about a group of kids, and if a group of kids in the neighborhood is playing, a group of 6 is pretty normal, and you think one of those kids in that group has a mental health diagnosis. But 70% do not get adequate care or treatment, and that is what is heartbreaking to me. And I'll be honest, one of the things in the South especially that holds families back from getting treatment for mental health is not feeling like, well, we're not doing the right thing as a religious family. Well, we just need to pray about it harder. Or we just need to, trust that God will take it away. Well, I'm all for prayer. And I'm all for trusting God, but I also know that God gave us resources. And God gave my son a kidney doctor. My son has chronic kidney disease. And I go to that urologist with him every month like I'm supposed to. And there is nothing different about taking your child to a psychiatrist. My urologist and the psychiatrist went to the same medical school. And so God gave us resources, and as His people, we are supposed to use those resources to better His kingdom. So, we're going to jump right in, and this slide is going to stay up for a long time because this is where we're going to stay a majority of our time today. But I really wanted to break down some of the most common diagnoses that we have in childhood mental health. Now, like I said, I'm in private practice now, or maybe I said that. I am in private practice now. I work as a private counselor over in Woodside Executive Park and have my own office. I needed a slower pace after working at the hospital for 13 years. And not only did I see these diagnoses very commonly at the hospital, but I also see them in private practice. These are the things that I am seeing kids and teenagers come in for on a daily basis. I'll tell you that my practice is not unlike other people's, but we have waiting lists of kids that are waiting to be seen for these mental health concerns. And so I just wanted to kind of go through and explain as many of these as possible, and also talk about these most common ones. So MDD. Okay, so just like in any healthcare, we're going to use a lot of acronyms. You know, we love the letters. We love them, people. So every one of them has letters, if you can't see that. MDD, PTSD, and sometimes that feels really overwhelming. And I know as a parent of a child who has a chronic health concern, I had to stop my doctors and I had to say, look, I'm very well educated, I'm in healthcare, I don't have a clue what that acronym is that you're using right there. Break those letters down for me. So I wanted to put the letters up there for you. So MDD is what a lot of counselors and psychiatrists are going to call major depressive disorder. And just like the psychiatrist talked about earlier today, this is most commonly characterized by 2 weeks of ongoing sadness, okay? So that's the most common. But here's the thing. Sadness does not look the same in kids and teenagers that it looks in you and me. When you and I are sad, we want to stay at home all the time. We want to draw the blinds back. We want to stay in bed. Kids and teenagers don't have that luxury a lot of times. Kids and teenagers do not show their emotions the same way that adults do. So a lot of times what you're going to see for 2 weeks of ongoing sadness is 2 weeks of, now again, out of character, irritability, anger, upset over little things that wouldn't normally upset them. These are some warning signs in kids and teenagers. A lot of times we'll say, well, they're just being a sullen teenager. Well, yes, that is true. But if this is completely out of character for them, and this is going on for 2 or more weeks, we need to, as parents, as pastors, as church leaders, as youth group, I heard you guys say that, as youth group leaders, we need to start saying, something seems to be going on with so-and-so. They also are going to have changes in appetite. They may be eating more, they may be eating less. They're going to have changes in sleep. They may be wanting to sleep all the time, and they tell you, even after I slept 9 hours last night, I'm tired. Or they may not be sleeping much at all. Some of the most common symptoms that I'm seeing in teenagers right now who have major depression is that they're telling me, I'm up till 1, 2, 3 o'clock in the morning and I just can't sleep. I just can't sleep. Now parents are thinking, well, they're playing on their phones and they're doing that, and that may be the case, but a lot of times they're using their phones as a distraction because they couldn't sleep even if they put them down. Another thing to look for in major depressive disorder is that this is the one, and I put it first for this very reason, that it's very common to have thoughts of suicide, okay? Suicide is different from self-harm. Self-harm is when a person is hurting themselves, they're cutting, they're burning, they're doing something to their body for the release of the pain. And that is very different. That also can be in major depressive disorder, but it's very different from suicide. Suicide is when a person is having thoughts of wanting their life to be over, wanting their life to end, and maybe even planning out the ways to do that. Suicide has a range. I have kids that come in, teenagers that come in, and they say, I'm not gonna kill myself. I mean, I'm not gonna go like get a bottle of pills, Miss Leslie, and kill myself. But every night I go to bed and I wish that I just wouldn't wake up. That is suicidal thoughts. that's different from suicidal plans, but still on the spectrum of concern and definitely one of the major symptoms of major depression. Now, I'm touching on the big ones. There are other things as well. Low self-esteem, that's a pretty common one in major depression. Inability to focus, which is interesting because oftentimes they will get misdiagnosed with ADHD. They'll say, oh, I can't focus at school. Well, if your child has focused at school for the last 5, 6, 7, 8 years, and all of a sudden they can't focus, it's probably not ADHD. It's probably a mild symptom of something like depression. So that's something to kind of be aware of as well. I could probably do a whole speech on just that diagnosis. And of course, the next one they are doing a whole speech on. But we're going to move on to PTSD. And I put PTSD next because PTSD is very relatable to major depression. But PTSD has the founding quality that there has been some sort of traumatic event that has happened prior to the emotional change, okay, or the behavioral change. Now, here's what's interesting. Yes, when he was talking out there about trauma, I was like, man, those numbers are just staggering. You know, he was saying 22% were checking yes on certain abuse things, and I found that study. I want to ask him about it later, but I found that study fascinating. But there are other forms of abuse other than just sexual and physical and psychological. I didn't mean abuse. There's other forms of trauma. I have worked with children in the past who were in a house fire and they woke up and their house is on fire and there's smoke everywhere. And the case that of course stands out in my mind back when I was a very young therapist, like 17 years ago, was several members of the family died in that fire and he got out and was now living with a relative, and that was a very traumatic, and he had every single checkbox of PTSD. So a traumatic event can be a horrible car accident. I've worked with kids who have been in a car accident where someone in the car passed away or where they were trapped in the car. And so trauma doesn't always mean abuse. I also worked for many, many years in the foster care system as a contract therapist for DFACS in Georgia. And even kids who were removed due to neglect, that was a traumatic thing. The neglect was a traumatic thing, but also, unfortunately, the way the foster care system is set up, moving from foster home to foster home to foster home can be very traumatic. So PTSD. So that's the number one quality to meet that diagnosis, is that there has to be a trauma that has occurred. And then after the trauma has occurred, there are long ongoing periods of things like flashbacks, nightmares, anxiety, depression, change in appetite and sleep, those kind of things. And so PTSD is definitely a little bit more specified than MDD, but oftentimes shares many of those qualities that MDD would have. We're going to move on down because I mentioned anxiety with generalized anxiety disorder, GAD. Okay, GAD we are seeing in staggering numbers after COVID. Staggering. I cannot even stress enough, this is the number one diagnosis I'm seeing after COVID. We flipped our kids' and teenagers' lives completely upside down. We didn't, COVID did. Yeah. But you think we had it hard? Yeah. They were completely, and still, I mean, we could raise our hands of those of us who have kids right now, how many of them have been quarantined for 2 weeks, and not just once, 12 times, you know? Right. It is unsettling to their nervous systems when they don't know what to expect day to day. They don't know what to expect. Think about how nervous we all were in March of 2020 when we went on lockdown. We were told not to go to work. We were told not to go to church. We were told, and we were nervous. Now imagine if you're a 12-year-old child and you're watching this transpire. And so generalized anxiety disorder has become very, very prevalent in the mental health system for adults and kids and teens. What we're seeing is social anxiety about getting back involved because we were told to stay in our house for 9 months, 10 months. You know, we're telling them now, no, go back to that Aiken High with 1,200 students, you know. We're telling them, you know, no, go back to that class of 40 kids, you know. And so social anxiety has been very high. School anxiety in general, about the schoolwork and about getting schoolwork completed and about the uncertainty of one day I'm in class and then the next day I'm doing online work and those kind of things. So the anxiety is just very, very, very high. Young kids, we also saw a lot of anxiety with going to sleep at night and being alone in the dark and things like that, because again, the world was so uncertain for so long and kind of still is. And so we're trying to regulate our systems. They're really struggling to regulate. And so they're having very high levels of anxiety. They're having panic attacks. They're having moments where they can't, they're having racing thoughts and they can't slow their thoughts down. They're having nervous habits where they're wringing their hands or they're rubbing their skin or they're pulling their hair. So those are the kind of symptoms to look for in generalized anxiety. It also is going to have the same characteristics of normally a change in sleep patterns, a change in eating patterns. Their mood is going to shift a little bit. But the way that we know we're dealing with generalized anxiety is that the predominant symptom, the symptom that you're seeing the most, is that anxiety, okay? We're going to move on to ADHD. Now, ADHD has been around very commonly since I was a little kid. You know, I can remember kids at school saying they had ADHD, and I'm in my 40s. So, you know, ADHD, one of the things that is a problem is that ADHD, I do believe a while back, was overdiagnosed for a while. And so then people got a little weary about it. Like, everybody says they've got this, you know. But the truth of the matter is that ADHD is when a child is, and ADHD in the new diagnostic manual, it encompasses ADD and ADHD. They call it all the same thing. Kind of like we'll talk about with autism spectrum. They just call it all the same thing, but there's breakout sides. But ADHD is inattentiveness, inability to focus and concentrate, inability sometimes, if you have the hyperactivity type, to sit still. If you have the impulsive type, it may be that you're doing things without thinking, you're grabbing things, you're blurting out the answer, you're doing those kind of things. ADHD also has a lot of really like underlying symptoms that we don't think about as much, like if a person has moderate to severe ADHD, their emotional maturity is going to be at least a year or two behind that of their peers. Because, and I had a psychiatrist that I used to work with that explained it to parents like this, and it always stuck with me. If your whole focus day in and day out for your 8-hour work day at school, which is what kids are doing, is I can't get in trouble, my mom and daddy are going to get it. You're not maturing emotionally. If you're so distracted that you're not noticing social cues, you're not maturing appropriately like your peers are. So one of the reasons that a lot of kids actually end up coming into counseling is because they have started noticing that they're emotionally immature compared to the people that they're in the grade with. It also leads to a lot of low self-esteem, okay? They're used to, for a long time, making those bad grades, failing, getting in trouble at school, clipping down, doing all the things. And so their self-esteem is oftentimes low. And then often something that also goes along with ADHD is anger. Anger is a very prevalent symptom of ADHD. They're angry that they have to deal with this day in and day out. Have you ever drank too much coffee or soda and you're jittery that day, and by the end of the day you're exhausted and you're just irritable? That's how a lot of ADHD kids feel all the time. And so think about how irritable you might be if that was your daily life. And also think about how irritable you would be if all day long somebody said, Felicia, stop moving. Felicia, stop picking that up. Felicia, stop doing that. That's how, and I use Felicia because she knows I love her. But that's why a lot of times you're going to see the irritability and the anger. And it's not that the teacher's being mean. I'm not saying that at all. It's just that they need a lot of redirection, and they don't understand why everybody else doesn't need that redirection as well. ODD, oppositional defiant disorder. ODD is the only one of these diagnoses that there is not a medication treatment for, okay? So there is a medication treatment for all of these other diagnoses. There is not a medication treatment for ODD because ODD is a special class of childhood disorder. It is only diagnosable in childhood and adolescence. And when you become an adult, that diagnosis goes away. You either learn how to deal with it, and I'll explain more of it, or you kind of become classified as a criminal or a delinquent or things like that. Because ODD is a behavioral diagnosis that is marked by things like not wanting to follow rules, not wanting to listen to authority, bucking the system. It is a very behavioral specific diagnosis, and it requires behavioral specific interventions. So parents of kids with ODD become very frustrated, and I go back to the speaker from this morning, and he talked about how certain diagnoses and things affect certain populations more. Well, normally it is the populations with less resources, because these are single parents raising their kids all by themselves and trying to do it, or these are kids that are struggling with other stuff and are acting out behaviorally. And so it's exhausting sometimes to have to put into place these behavioral interventions, and that's why it's really important if your child or if a person is diagnosed with ODD, that you really work very closely with a therapist or a counselor in developing a behavioral plan to implement, and here's the key, are you ready? All the time. So here's where I'm asking you pastors, you church leaders, you nursery volunteers, all of that. If a parent comes to you and says, we're working with so-and-so therapist in town and they're asking us to do a reward system. So if Joe sits through the youth ministry, will you let me know, or will you give him this as a reward? You jump right on that and you say yes, and is there anything else I can do? Because these are the families that do not have Adderall, Ritalin, Prozac, all of these things to help. These are the families that need strict reward-based rewards and consequences, okay? And they have to be loving consequences, and we talk about that a lot in treatment. But so if a family ever does come to you and says, my child has ODD, or we just got this diagnosis of ODD from our psychiatrist, this is a great time for you to say, oh, well, I heard that it's very helpful to have a behavior plan set up. I, work with him every Wednesday and Sunday, so tell me what your behavior plan is so I can do it here too. I can't tell you how much a parent would be like, really? That is awesome, because nobody understands this with this diagnosis, because everybody says, well, can't you give that kid some medicine? Well, maybe if he's got ADHD too, he can take a medicine that's going to help a little, but this is a behavior that we need to change. And so they need loving reinforcement from the teachers, the church, the family, all of those things. They don't need grandparents. I love y'all, but they don't need for Joe to go over to your house on Friday night and you to go, I know your mama said you can't play video games, but you can do it here. Yeah. They don't need that. Mm-hmm. If mama said Joe lost his video games for today, grandma and grandpa, you got to stick with that too, as hard as that is. Because they have to have that constant reinforcement. Because you and I know the day they turn 18, the police officer's not going to go, now at our house, you get this, but you got to act this way out in the real world. No, that's not how the world works. So, DMDD. Raise your hand if you've heard of DMDD. A couple. I'm actually impressed. We got like 5. It is a brand new diagnosis, and I could not be more excited about this diagnosis being added to the DSM-5. And let me tell you why. Bipolar disorder, which has been very openly discussed, is very commonly misdiagnosed in child and adolescent treatment. Or it's not misdiagnosed by a psychiatrist, it's misdiagnosed by people that don't understand it. Kids and teenagers do not qualify for bipolar disorder very often. Did you notice the psychiatrist up there talking about 10 years? That kind of stuff. That is very. I really was excited when he said that 10 years of difficulties, because kids and teenagers are going up and down anyway, because they've got hormones and they've got development and they've got. I'm going to middle school, and I'd probably seen bipolar too if I was at middle school. God bless you if you work there, or if you work with middle schoolers. But DMDD has kind of taken the place in the mental health world for kids who are having mood swings and kids who are having behavior problems. So DMDD kind of encompassed what we were missing in the child and adolescent psychiatry world, where parents were saying, I think my kid's bipolar, and I got why they thought that, but what they didn't understand was we can't diagnose bipolar after 6 months. Yeah. It's just not, it's not adequate timing. And so DMDD took what was very specific in childhood, which is that kids and teenagers are going to have ups and downs, but it said these are more frequent ups and downs than the normal. These are more frequent mood swings. These are more severe behavioral problems. So it encompasses that there's mood swings and that there's behavioral problems. And I'm giving y'all a real basic breakdown, so just know that this is a really interesting diagnosis, and if you're working with a family that's saying things to you like, I think my 12-year-old's bipolar, give them the name of this and tell them just to read up on it, because 9 times out of 10, I think they're going to say, that fits, because it really does encompass a lot better what happens with kids when they're having severe highs and extreme lows and their behavior is all over the map. Lastly, want to touch on autism spectrum. This was one that I was not as happy when the DSM-5 put it all under one umbrella, because it used to, those of you who may have heard of this, there was something called Asperger's disorder, which was high functioning autism. Yep. I love that diagnosis. I can't believe they got rid of it, but I'm not in charge of the DSM. So, but autism spectrum now encompasses everything from very high functioning, just socially awkward, don't pick up on social cues, unable to kind of make eye contact, those kind of problems, to unfortunately all the way at the lowest functioning, which is nonverbal, You've probably seen the hand flapping, the tics, the, very, very sensitive to overstimulation of lights, of noises, of even textures. I work with kids that I don't do very much work with autism. I will only work with the highest level because of the scope of practice and private practice that I can do. But even just texture issues, like I have one kid that will not wear socks, just will not. And his mom gets so upset about it. And I said, why? Why is that our battle we're fighting? I don't care if he wears socks. You care if he wears socks? I don't think anybody cares if he wears socks. You just think that because you're his mama, that you need to make him wear socks, because that's what us mamas do, is we think we need to make him wear the socks. But that's just not the battle to fight, especially with autism spectrum disorders. And so autism spectrum, again, is the very sensitive to overstimulation, very socially awkward sometimes. Again, it can be anything from just not getting jokes or social cues that, we're supposed to take it from laughing to serious and things like that, to, again, the can't talk, can't make eye contact, hand flapping, those kind of things. So those are the most common. Those are the diagnoses that you are going to most commonly see in kids and adolescents. Are there others? Absolutely. But if I had to narrow it down, I would actually say that this encompasses 98% of my practice. There are a few others like OCD. You've probably heard, again, we get in the letters, OCD, obsessive compulsive disorder, and there's a few others where you can get really specific with your anxiety, like a phobia of something. But for the most part, this is what we're seeing a lot of. And I do know that there's probably going to be some questions. I'm going to go through the slides real quick, and then that way we have the rest of the time for questions. Some factors that can contribute to these diagnoses. Parent-child relationship problems, okay? So this is where there is a conflict between the child and the parent. And this can be due to parents being stressed. I mean, I know that I've come home some days and had a hard day and not been especially in a nice mama, that happens sometimes. But when it happens on a continuous basis, it can cause problems. Also, it can be caused by the child antagonizing the parent. That can be part of the problem. And so anytime there's a clash of just even sometimes personalities, I'll use my own mom and sister as a example. My mom's a lot like me. She's very, organized and likes things done the certain way. And we might have a touch of OCD, not enough to be treatable, but might have a touch. Well, my sister is not. My sister doesn't care if her kid's hair's brushed. She doesn't care if they're wearing the socks. If they're having fun and outside playing, they live out on a big farm. I, of course, work and love my job, and my mom worked my whole life. My sister, she ain't interested in working. She likes being at home with her 4 babies, and it's just very different. Well, my mom and her, you can imagine growing up, clashed all the time. And they did. They went to counseling together when my sister was about 13 because they just could not find common ground. My sister did not understand why making her bed up was so important to my mama. And my mama didn't understand that probably wasn't the battle to fight with my sister. And so it was little things like that. So parent-child relationship problems, divorce. I see a lot of kids that come from parents that are going through divorce, who have already been divorced and are not co-parenting well. If there's one thing I can say in this room as church leaders, if you have people in your church coming to you and saying, we're getting a divorce, what do you think we should do? Number one thing is don't talk to the kids about the other parent, ever. If they say, Daddy has a new girlfriend, they say, really? Okay, thanks. No questions. No, I can't believe he did that to us. No, well, you don't even have to be nice to her if you don't want to. You just tell him. None of that. none of that. And I'm just using that as an example, but the number one thing that will cause anxiety in a child is parents who can't get along after separation and divorce. I know that parents are getting divorced because they don't like each other anymore, but we got to love our kids enough to bite our tongues sometimes and to be the bigger person and to not talk about the other parent. And so I asked a child just a few weeks ago that I'm working with, if you could have one wish, if I could wave a magic wand, what would it be? And she said that my mom and dad wouldn't talk about each other. You know, so it just is, it's so harmful to their self-esteem, to their mood. Child abuse, I think that one's kind of obvious. Of course, that leads to many of the diagnoses, not just PTSD, but many of the others. Bullying, I don't know about y'all, but I grew up in the 80s and the 90s, and everybody got a little bullied. You know, I mean, we were all, you know, everybody got called a little name. It was nothing like it is now. Kids will bring in their social media and show me where somebody wrote on their page, just go home and kill yourself. We would all be happy. The bullying is at a newfound level. You know, years ago, about 10 years ago, I used to think, these kids are just blowing things out of proportion. You know, my dad used to tell me the story about every freshman on the football team got thrown in the trash can. You know, like that was their initiation into football. But he said, but then they pulled you out and you were part of the team, you know. That is not what our kids are, you know. That is not what our kids are experiencing when they talk about bullying. They talk about relentless. I'm talking, one kid showed me over 4 hours of their phone going ding, 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 of like 4 kids saying, you're so ugly, you should kill yourself, nobody likes you. Social media and cell phones are very, very dangerous when left unattended. So parents, church members, tell your families, watch the cell phones because of other kids and the bullying that happens. And so, as you can imagine, that leads to all kinds of self-esteem, anxiety problems, depression, just even PTSD, I would say, in some cases. So I would say, and again, bullying and social media access, I put them right beside each other. You know, just the things that the kids have access to nowadays that we did not have access to. I think back in my senior year, we got a computer in our living room, and you know, the old one, everybody in the house knew you were logging on, so you better not be doing anything bad, because I mean, it didn't matter if you were sleeping with, you know, sleeping meds, you heard that. Nowadays, I mean, I'm logged on to the internet right now, I'm pretty sure, you know, we probably all are. And so the access that they have to those kind of things is just sometimes overwhelming. And I have parents a lot of times, especially again for ADHD kids who are impulsive and don't have that filter a lot of times, and their parents will say, you know, they're upset because I'm limiting their social media access. And I say, you know what? They're gonna just have to be upset, because them being upset about you limiting it is a lot better than them very quickly. I was talking to a parent of a 12-year-old girl not long ago, and they said, we're just so scared she's gonna snap a nude and send it to a boy. We're so scared. And I said, you need to be scared, because this child is so sweet. Gosh, I love her to death, but so impulsive. And I could see her thinking, I'm fixing to get his attention and he's gonna like me and I'm gonna be his girlfriend, and then it's out there forever. So, genetics. I'm gonna raise my hand first. Raise your hand if someone in your direct bloodline, that means parents, grandparents, or great-grandparents, have depression, bipolar disorder, anxiety. Yes. Genetics. Now, it does not mean that you have to have it. I have been very blessed. My mom, this is how I got introduced into the mental health world. My mom battles major depressive disorder, and has since I was a young teenager. And I fortunately have not. I've been very, very blessed. And but with genetics, I have kept a very close eye on it. When my son has had all of his surgeries, he's had 15 now, around surgery time, I do a mental health check and I go, am I okay? Am I doing this right? Am I getting grumpy or sleepy or eating too much or doing all the things? Because I know that my genetics predispose me to that. So one of my first questions on my questionnaire when I meet a family is, tell me about your family background. Tell me about Aunt Cindy, who nobody talked about, but who probably had so-and-so. Or tell me about, you know, what we may have been seeing. My Nana, sweet, sweet woman, sat in the fourth row of the Baptist church every Sunday of her life. But when my mama started going to a therapist, my mama lost some weight because she felt good and was doing what she needed to and taking care of herself. And my Nana called that therapist her weight loss doctor, because you don't talk about therapy, honey. No, that's her weight loss doctor. So when I told my Nana what I was going to be, she said, you mean like Angie that helped her lose weight? And I said, yes, ma'am, that's exactly right. Sweet, sweet Nana. But genetics will play a huge role, and so we need to be careful that we're not hiding things. I had a family come in a couple of years ago, and they told me, we brought him right in because he was talking about suicide, and he doesn't know this, but his daddy killed himself. And I said, he's like 12. He's going to accidentally find out because somebody's going to say it. Genetics are not meant to be embarrassing. Genetics are just part of who we are. Nobody hides that granddaddy died of heart disease. Nobody hides that, you know, brother died of lung cancer. Smoking isn't good, but we don't hide it. So we need to get rid of that stigma and realize, now age appropriate, of course, but we don't hide things. And I love that Philip and Terry are taking some of the stigma away from talking about suicide. Because it's nothing to be ashamed of. It's nobody's fault. It's not anything that you know, is anything to be embarrassed about. And so genetics is real important not to hide. Low self-esteem, of course, would lead to a lot of the diagnoses. Drugs and alcohol, yes, and they're rampant in our schools, unfortunately. And then LGBTQ issues, and I could again do a whole presentation on this, but I'm going to try to wrap up. This one though, let me just say, as church leaders and as a person who has been a strong Christian since I was 5 years old, and I am very secure in my salvation at 5 years old, but I can believe the Bible and also love every person that comes into my office. Right. And if a teenager comes into your office and says, Miss Felicia, I'm using her again, Miss Felicia, I think I'm gay, Miss Felicia cannot say, well, you're going to hell, honey. No, ma'am. That child is at high risk for going home and thinking about killing themselves, because they'd rather be dead than think about, well, if I am gay, then I'm going to hell. So I had a child tell me that 3 days ago, that their church leader told them when they went to them in confidence, well, you're going to hell. As church leaders, we can have strong beliefs on what is sin and what is not. But I was always taught, and I'm going to tell you this as a counselor, you can hate the sin and love the sinner. That's right. You love. There is nothing wrong with your child. They are not possessed or anything, because you know what? We all have things that we struggle with. So I'm telling you right now as church leaders, do not tell that child they're going to hell, because you are promoting mental health problems. Right. You love that child, and you tell them, I love you. I'm so proud of you for telling me this, and I love you so much, and I'm so glad you trusted me. And what can I do to love on you? So I left that one for last because it's emotional for me, because I hear a lot of kids come in, and we live in the South, and I'm very strong in my faith. And it makes me sad when people feel like they can't go to their own faith leaders, you know. And so we need to make it known that I'm going to love you no matter what you tell me. You told me you stole a candy bar a year ago, I'm going to love you. You tell me that you are struggling with your sexuality, I'm going to love you, because love and hope goes a huge, huge long way when treating mental health problems in kids and teenagers. Kids and teenagers just need to be heard. They need to be understood. They need to feel like they're not going to get in trouble. They're not going to be judged. So, all right, I'm going to go through. Individual therapy is one type of treatment where the child or teenager comes in by themselves and works on the problem with a therapist. Family therapy is a huge part of treatment where we bring in the parents and even sometimes siblings or grandparents or caregivers and work with it. PHP is something that Aurora Pavilion offers, and it's only for teenagers though, 12 and up, but it is a 2-week Monday through Friday program. And if a child is in crisis, maybe they're not like planning out their suicide, but you've seen kids in crisis, like they need help today. This is a fantastic option. You get in at 9 o'clock in the morning, you leave at 3 o'clock in the afternoon. You see a counselor for 6 of those 7 hours, only because the counselors got to make phone calls. Do you not see them the whole 7 hours? But you see a nurse, a psychiatric nurse. You see a psychiatrist every other day. It's a fantastic option if you are in crisis. Inpatient hospitalization. These are the scariest words that a parent or a church leader will ever hear is, I think you need to go into the hospital. Nobody wants to drop their kids off, and especially right now with COVID, because you drop them off and you pick them up 5 days later. There's not visitation right now, which was heartbreaking as a therapist when I was there during COVID. But it lasts about 5 to 7 days. That's normal length of treatment. Anybody who tells you it lasts 3 days, I'm sorry, I know we're in church, they're lying. It doesn't last 3 days. I worked there for 13 years. It doesn't last 3 days. We can't get it all done in 3 days. If you're sick enough to be in the hospital because you've tried to kill yourself, done something really bad, planned out how you were going to kill yourself, you're psychotic, you're completely out of control, something like that, you need a full evaluation, and that just can't happen in 3 days. So I say that because I had kids come in and they said things like, well, my preacher said that I was going to be here for about 3 days. And I'm like, sweetie, no, that's more like 5 to 7. But we try to explain, because we want to give you the right kind of care. We want to make sure you leave on the right medicine. We want to make sure we've got a good plan in place of who you're going to see when you leave here. So. And then medication management. Unfortunately, there's not a lot of psychiatrists in our area. That's just the state of the union that it is. But some pediatricians, some will do that. It depends on who your pediatrician is. There are some nurse practitioners in town that are really good at managing mental health medications. And then, of course, there's AU Health in Augusta, and there's Prisma Health in Columbia that has some psychiatrists. Let me just say real quick, and I wanted to be doing questions right now, but medication. As church leaders, as church people, we need to let our families know that it's okay to take mental health meds. Amen. That it is just the same as taking your blood pressure medicine, that it is just the same as taking your ear infection medicine. We need to take away the stigma. I will hear people say all the time, well, my Sunday school teacher said I don't need this anymore. Well, I didn't know your Sunday school teacher went to medical school. That's just amazing. That's great. Tell me what that doctor's name is. Well, my Sunday school, or my so-and-so said that if I just pray harder, I could get off my medicine. You know what? Again, we don't treat other health concerns that way. We combine prayer with the treatment. We combine all of the things that we do in our faith with the treatment. And so I would just urge you that if somebody tells you that they're on mental health meds, say good for you. say, how can I help? Don't say, well, I heard that's not good for you. Well, I heard that has terrible side effects. Don't bring up the negative parts, because most of them really don't. The side effects you hear about normally are in a very small percent of the population. So, I just added this slide. In 2015, adding spiritual practices to treatment it decreased the likelihood of suicide. And you can read that better than I will, but just, people have begun studying how when we combine our faith aspect with mental health treatment, instead of keeping them very separate and very different, that it works a lot better. And then religion can encourage social connectedness and can increase our number of resources. It gives us a sense of meaning and purpose. I can't tell you how many people that when they are suicidal, part of getting better is finding purpose. And so as a religious community, if we can give them that purpose in Christ, then we're giving them hope. It works together with treatment. It does. Again, we don't tell cancer patients, stop going to your cancer treatment and just come to church. We say, let's do both. Let's love on you as a church. Let's take meals to your house when we're having a bad, we do it all the time for people who are sick. Let's start doing it for people who are in mental health crisis. Yeah. Let's take them meals. Let's offer, I'll come pick you up on Sunday morning. I know driving's been real scary for you lately with your anxiety. Or I'll do this. Can I take your youngest child for a few hours because I know that so-and-so has been struggling, your older child's been struggling, and you might need some time with them. We can love on people with mental health the same way we can love on people with physical health problems as a church. Active listening, refer them to a licensed counselor or therapist, be open to medication, be an encourager and an advocate, not a judge. And if a child or teen talks about suicide and asks for help, do not ignore them or tell them it will be okay. Take it seriously. Resources in our community. I think that's my last slide. Yes. That one I'm going to leave up, so feel free to take pictures of it or to come up and look at it. I just wanted y'all to leave with a list of people in our community that do child and adolescent treatment for mental health. And so this is a list that I use, and it's not a know-all be-all list, but it is a list that we use a lot. So we do have like 10 minutes. Yes, ma'am.
I have one thing that, in working with kids I'm only 25 years old, I'm working on my MSW, but in working with kids and in my personal life experience, real briefly, I was diagnosed under the DSM-4 with anxiety, depression, and OCD when I was 9 years old. So you can do the math. But one of the things that I did as a child that I feel like when it comes to parents or adults that are in positions of authority kind of miss is my parents are both in healthcare, and they were like, why is she misbehaving every time she comes home from school for 3 months straight? And what they didn't realize was that I was internalizing all of my anxieties.
Yes.
For years, or for months. And so they just treated me like I was a naughty child. And then when they finally took me to the only child psychologist / psychiatrist, so there were two, they realized, oh wait, she behaves perfectly at school. It's only 30 minutes when she comes home, after she gets home from school, that she comes completely unglued. And so that was actually a really good catch on the part of my providers. But I feel like there are so many children, and I just had a recent interaction with one of the ones in our church where they internalize it, and then the parents just think they're naughty children, and then the next thing you know, I'm like, wait a minute, no, they're just internalizing their stress. They need a way to let that go.
They need an outlet.
And for me, being an athlete, my way of letting that go was playing sports. So for my parents to say, you're not going to soccer practice tonight, was not necessarily a good thing.
Right.
So that's one of the things that I really encourage a lot of, youth leaders, everything, just from my experience, is that, it's sometimes the DSM has this, these strict little codes, but not everybody fits in these perfect little boxes.
Absolutely.
And they were like, why is she having these fits of rage that go on for 2 hours, 30 minutes after she gets home? Well, because I was too busy trying to be a perfect little child in school.
At school, right. Yes.
And
I'm
so
coming to you. I'm going to go to her
was,
first.
completely confused.
Yeah.
They were like, she's perfect in school. She doesn't have a problem.
Yeah.
No,
I
have a big
agree.
problem.
Yeah, I agree. Oh, thank you for a minute. Thank you. Yes, ma'am.
What do you recommend is the minimum age for social media access?
So I believe, I'll give you the honest answer. My kids at 4 and 7 have some social media access because we have YouTube Kids on my phone, and we also have the Bible app. Not the regular Bible app. We all grew up with Superbook app. Thank you. I'm like, I can show it to you. It's right there. So they have some social media access, and I believe that it's not so much as far as I'm kind of that way with everything. If I tell a kid you can't wear makeup till you're 14, at 12 they're going to be sneaking it. Why not let them put on a little lip gloss at 10 and then put on a little powder at 11? So I kind of feel like it's the same way with social media access. If we ease our children into it, then they're more likely to be responsible with it. And also, if we ease our own selves as parents into it, where we're monitoring everything that they're looking at. Right now, that's all my kids have access to is YouTube Kids and Superbook. But that would be, I wouldn't say there's a minimum age. I would say we ease them into what they can and can't do. Yes, ma'am. I'm coming.
Excuse me, I'm a retired nurse. I want to make a comment about on the drugs. A lot of people don't understand that energy drinks are very bad for people who have mental health issues.
Yes.
And the other thing about autism, we have 2 grandchildren on the spectrum, and people tell me they only want to eat chicken and hot dogs and cheese. I mean, the textures of things, and people don't understand. I mean,
you know what? They're eating. That is not the battle for anyone to pick, but yes, you have to be their advocate and say, you know what? But at least they're eating, and theirs is a texture issue. It's not I'm just saying no to something. It's a texture issue.
So I'm a youth pastor. What role can I play in, because I'm never going to diagnose somebody, right? That's never going to be a thing, but how do you broach that conversation with a parent to say hey, it's not just your kid, because there's a particular kid who at one point in time the parents were just I'm sorry, my son just acts up, whatever, and it's it's venturing into that ODD. Yeah.
Well, and I think that you use this and overflow as kind of your out in a way. You say, I've been going to these conferences and I've been reading this information and I want to give you some on it, and I wanted to let you know that these are some providers in town, and I don't know what's going on with Johnny, but Johnny meets a lot of the things they've talked about at these conferences, and maybe it'll help you and him. I always say use things like this as your excuse. Make it sound like, well, now it's on my radar and I just wanted to share with you something I didn't understand before. I think that's a good way. I think coming in with them as a way of love, just saying we love having him in the youth group. Yeah. I'm so glad he's here. I'm so glad that we can love on him. one of the things that you're saying you're struggling with is the behaviors, and I've seen what you're talking about, and I heard in this speech that you can talk to somebody about that, and there are things they can do. And so just kind of coming at it, I think, from a real loving place, because I think probably what's going to happen is that mama's probably going to crawl on your shoulder and say, you just don't know how bad it's been at home, you know, so. Oh, it's 12 o'clock. Okay, so what I'm going to say for any other questions is I'm going to be right here. They really want us to like wrap up, but I'm going to be right here. Feel free to stay after and ask me any questions, and feel free to find me anytime throughout the conference, okay? Thank y'all so much.